Welcome to RUMC Connections. Welcome to RUMC Connections. I'm your host, Meredith Gaskins. On previous episodes of RUMC Connections, we've talked about the importance of recognizing medical emergencies early and knowing where to turn for expert care. Today's conversation builds directly on that, because when it comes to stroke, awareness can truly save lives. When most people imagine a stroke, they picture something sudden and dramatic, but the truth is some strokes don't arrive with obvious warning signs, and some happen silently, causing damage long before a person even realizes what's happening. Even more surprising, stroke is no longer just a concern for older adults. We're seeing more cases in younger, seemingly healthy people, and too often the early signs are missed or dismissed. At Richmond University Medical Center, patients have access to advanced rapid response stroke care, specialized neurology teams, and life-saving treatments designed to protect the brain when every minute counts. Joining us today is Chief of the Department of Neurology and the Medical Director of RUMC Stroke Center, Dr. Allan Perel. Thank you so much for joining me.
Thank you for having me.
Of course. Dr. Perel is also the immediate past president of the New York State Neurological Society, and he's here to help us understand the strokes you don't see coming, what symptoms people ignore, why age doesn't always protect us, and what everyone should know to act quickly and protect their brain health. So this is a conversation you'll want to hear and share. So just to give you a little background on Dr. Perel, he is a board-certified neurologist with more than 4 decades of experience caring for patients with disorders of the brain and nervous system. He is chief of the Department of Neurology at RUMC, where he plays an important role in the diagnosis and treatment of neurological conditions, including stroke and transient ischemic attacks. Dr. Perel earned his medical degree from SUNY Downstate Medical Center and completed his residency training at New York Presbyterian Hospital. He spent much of his career serving the Staten Island community, combining clinical expertise with a patient-centered approach to care. At RUMC, Dr. Perel works closely with multidisciplinary teams to provide timely, advanced neurological care and is known for helping patients and families understand complicated conditions in clear, practical terms. So his long-standing commitment to the community has made him a trusted voice in stroke awareness, prevention, and recovery. I'm very grateful to have you as my guest. And most people think that they would immediately know if they were having a stroke. Is that actually true?
Many people do.
Okay.
If you can't talk, if you can't move one arm, one leg, if you're having problems with your vision, people know that something is happening.
Mm-hmm.
But many times you get more subtle signs.
Okay.
Things like balance problems, dizziness, and it's very hard for the individual to know what's happening to them.
Okay.
Or what the diagnosis is. That's why we have so many patients being told, please come to the emergency room. Don't go take a nap, basically. See if you can seek immediate care. If it comes in and it turns out you don't have a stroke, great.
Yeah.
If it turns out you do, it's so important.
Of course. So it's better to be erring on the side of caution, just in case, right?
Yes, absolutely.
Okay. So is it possible to have multiple strokes and maybe not realize it until much later?
Interesting. If I get an MRI, some very sensitive imaging studies, or a CAT scan, or even more so the MRI, in patients over, say, the age of 50, very commonly we'll see small strokes that have occurred. Mm-hmm. And we ask the person, have you ever had anything like a stroke? And again, we talked about blurred vision, weakness, numbness, and many a time, even most of the time, they'll say no.
Okay.
And the reason is the brain's a big place.
Yeah.
And you could have very small strokes in different parts of the brain and have no clinical signs and not even know that you had it.
Wow. That's fascinating. Okay. So if someone suspects that they may have had a mini stroke or a silent stroke in the past, what should they do now?
It all depends how they know about it. If somehow somebody comes into my office with a headache and we get an MRI and we see it, basically we go back to looking for what's called primary prevention, or seeing what could have caused it in the beginning.
Okay.
Does someone have high blood pressure? Are they taking their medicines properly? Are they on the right medicines? Is their cholesterol level high? The use of statins have become so commonplace right now. if someone hasn't had an EKG or a heart workup, cardiac workup, seeing if they have an irregular heartbeat, something called atrial fibrillation.
Yes.
So we're going to look for causes.
Okay.
Most of our patients in this category will also do what's called an ultrasound of the carotid arteries, called a Doppler, to see if there is any narrowing that we didn't know about. So there are a lot of different things we could look for in order to see if someone may go on to have another stroke.
Okay.
Sometimes we never find an answer. About a third of the times it's called cryptogenic or idiopathic. We never have an answer as to what the cause of the stroke is.
Interesting. Okay, so what exactly would you say is a silent stroke, and why are they so dangerous if people don't feel them happening?
Interesting. Silent strokes, they're an additive effect.
Okay.
So if there's only so much brain that we have.
Yeah.
And if someone has strokes in multiple parts of the brain over a period of time, they are much high. They have a much higher risk of having dementia, cognitive problems, in addition to the stroke symptoms.
Okay.
So there's actually an entity called vascular dementia. Vascular dementia means dementia. Most dementias are related, at least a majority, to Alzheimer's disease. That's a predetermined process where through genetics and environment, a number of reasons, some proteins called amyloid builds up in the brain and you get this cognitive problem. Sort of like bubble gum in the brain.
Yeah.
But another cause of stroke, and there are many causes another cause of dementia, and another cause is vascular dementia. People having multiple strokes will cause the brain not to function as well.
Wow.
So if you can't talk from one side to the other because there's a stroke there and it's blocking it, it's a scar basically.
Okay.
Then you can get cognitive problems. People who have these small strokes over the years, that additive process will oftentimes lead to cognitive issues earlier than other people.
Okay, so these strokes will cause a sort of scarring on the brain, in a sense.
Almost by definition, when an infarction or death of tissue, what happens?
Okay.
If you think about if you cut your arm or
Yeah.
something happens, you
can
get
have
a
a
scar.
Okay.
Same thing happens in the heart. If you have a heart attack or myocardial infarction, you'll get a scar there. Here we get like this area of tissue that's not working, and the body scars over that area.
Okay. Interesting. And so we've talked about recognizing stroke risks and warning signs, but for many people, the journey doesn't necessarily stop after the emergency. So I also want listeners to know that RUMC offers the first and only stroke support group on Staten Island, a space for stroke survivors and caregivers to connect, learn, and heal together. That kind of ongoing support can really make a difference, for somebody long after they leave the hospital. So could you tell us a little bit more about that?
Sure. So when you think about it, when somebody comes in with a stroke, and hopefully they have a non-life-threatening event. People with very large strokes oftentimes will have a life-threatening event. They'll be in the intensive care unit. There's bleeding in the brain. There's just a very large stroke, and people are oftentimes left with very large, devastating residual.
Okay.
If someone has a small stroke, they might be left with mild residual, and when they go home, they're going to need help.
Yeah.
They're going to need help. Even many times, people don't even go directly home. They go to a short-term rehabilitation center. And the two things that get people better with stroke, other than all the interventions we might talk about later in the first few hours, is time. There's a recircuiting of the brain in order to make it work, and physical therapy. And maybe rehabilitative therapy is a better way to say. There's occupational therapy, more involved with the arms, speech therapy, more involved with speech, obviously, and physical therapy involved with walking. So those are the things that come together. But when someone does get home, their family has to be educated. People want to know that other people, how they're doing with the same situation. So us having this wonderful support group meets every 2 months, every month, we take the summers off, is a way for a whole group of people to come together and talk about their problems. And you really can't understand the problem of someone else unless you have it yourself.
Exactly.
You could read all the books, even as a neurologist, even what I do. You can't really be in someone's shoes until you're actually there.
Of course.
And so that's where patients and people and their caregivers are able to learn a lot. And even things like what services are available.
Yeah.
People don't know where they can get a doctor to come to your house to evaluate you, where you can get a physical therapist to come to your house. What benefits, through various Medicare and other agencies, we can give patients in order to get the services that they need. So a lot of it comes through our hospital with social workers, some of the short-term rehab centers with their social workers. but still, hearing it from someone else
of course, they
really
can
helps.
relate. Absolutely. And this support group is completely free, right?
Absolutely.
Okay,
And we even serve coffee and light snacks.
How nice. That's great. No, it's very important. And, and it's a sense of community that it's other people from the island, like you mentioned. And, they can compare services and discuss, symptoms and, have somebody to.
And everything's
relate.
local. The services that you want are the local services. What we see on national TV, or we hear about an event, a walk, a bike-a-thon, it doesn't really affect you unless they have that service on Staten Island. And so often we haven't been gotten all the services that New York City gets. And that's a whole different story as itself.
Yeah, of course. I know we're a little behind. So would you say that there's certain maybe medical conditions that quietly raise stroke risk that people rarely talk about?
I think we talk about it a lot. It's blood pressure. It's hypertension. We've been proud and happy over the last 20 or 30 years for the risk of stroke in most patients to have gone down dramatically because of hypertension control, blood pressure control.
Yeah.
Now, interestingly or sadly, we're seeing a spike upward. And there's a lot of debate about it, lifestyle issues.
Yeah.
People are always online. People are not doing enough exercise. People are not going to the doctor as much. Stresses, again, it's hard to say whether the stresses are worse now than they were 20 or 30 years ago.
Yeah.
But and even blood pressure management, compliance, people aren't taking their medicines. There's a lot of issues going on with it. But blood pressure is 1, 2, 3, 4, 5.
The number, okay.
After that, of course, cigarette smoking, lifestyle issues, as we said. A big one that we see on television recently is atrial fibrillation. That there are medicines and blood thinners for people who have an irregular heartbeat. It's the top of the heart where if it quivers instead of pumps, blood that sits around clots.
Okay.
And that clot would go then throughout the body. And if a clot goes into the brain, that's what causes a stroke. So atrial fibrillation is a big deal.
Okay.
In younger people, trauma, drug use. We also have seen a big uptick when COVID-19 was around in the form that 2020, 2021.
Okay.
We were seeing a lot of patients with stroke because COVID caused inflammation, and the inflammation caused the blood vessels to constrict.
Okay.
So we saw a lot of people with stroke. The variation of the COVID virus now is not as devastating with regard to inflammation now.
Yeah.
It's more like closer to a cold or a bad upper respiratory tract infection than it was back then. So we're not seeing that spike with COVID patients.
That's interesting. I didn't know that. Would you say that there are screenings or tests people should be asking their doctors about? I guess they should be checking their blood pressure, their hearts, making sure that
cholesterol.
Their cholesterol. Okay, so getting all the standard.
EKG. I mean, it'll tend, and this is where you were talking to me before. It's what age group?
Yeah.
So if you think about it, yes, everyone over 65 should have an EKG or ECG, heart tests, all kinds of things like that, blood cholesterol levels, blood sugar testing, blood pressure. What if someone is 25? Do we need to get an EKG on every 25-year-old?
No.
In some people we do if their heart if there's any irregular heartbeat or there's a murmur or something that we're hearing. But the question is, how far back do we go? And the statistic that really shocks me is 1 of 10 people with strokes are under the age of 45. Wow.
So what do you think is causing that?
A lot of things. Trauma, as we said before, lifestyle issues.
What sort of trauma do you mean?
Car accidents, falling, athletic injuries.
Got it.
What happens is you can actually, from trauma, rip an artery, especially in your neck.
Okay.
The neck's sort of a delicate area.
Yeah.
So if you turn quickly, or not turn, that almost sounds so benign, but if you get hit playing football quickly, or if you fall when you're in a car accident, some of the blood vessels like the carotid artery or an artery in the back called the vertebral artery sometimes rip. And that can cause a stroke also. So that's called an arterial dissection.
Okay.
So that's something we always have to look for with young people. The other thing with young people is some people are genetically predetermined to have a fancy word called a hypercoagulable state. Thick blood. They clot easier.
Okay.
And they clot easier because they have diseases like lupus, various inflammatory diseases, very high cholesterols, too many platelets in their blood. And some people just have a genetic predisposition to clot more.
Okay.
And those people, as younger people, can have strokes.
So you think we're seeing more of that's causing?
I think we're diagnosing more of that because, again, the number of people that we don't know the reason for their stroke has shrunken. When I was a resident, it was about 50% of people we never got an answer. Now we're about a third to 30%.
Okay.
But we still have a lot of people that we don't know what caused their stroke.
That's very interesting. Are there any changes in testing that you're seeing or any, improvements that you think will possibly address that one day?
I think, of course, MRIs have really been able for us to find the smallest of small strokes.
Yeah.
It's still not perfect.
Okay.
People sometimes have had a stroke with a normal MRI, but we could see smaller and smaller things based on the higher power of the magnet, the resolution of the new imaging studies. Mm-hmm. So CAT scans, MRIs are really crucial in that diagnosis that we have. Again, all the other tests like echocardiograms or tests of the heart, artery tests that we look at, all help us. Mm-hmm. Blood work has gotten more sensitive. We have new blood tests, as I said, for the genetic factors. So there's a lot more science that we have. Yeah. But the idea is recognizing the problem and determining in any individual who we get a test for.
Mm-hmm. Okay. That makes sense. So, I would assume that you have a lot of interdepartmental, work. You work with a lot of the cardiologists, patients as well. Right?
Absolutely. So, say someone comes in. There's a gentleman who just came into the hospital. Mm-hmm. He was coming on a flight home from California.
Okay.
And he got off the plane and he went to get his luggage and he felt dizzy. Huh. And his balance was poor. Okay. And he couldn't walk straight. Oh. Came to the he got picked up. His family said, "You're not feeling right." Took him right to the hospital. And in the hospital, we diagnosed him. This was a 28-year-old person with a stroke. Huh. He had a stroke in the back of the brain. So, and his symptoms were dizziness and feeling fatigued. And our workup becomes very extensive. We look to see if he has a hypercoagulable state, that thick state, to see if he has a hole in his heart, that sometimes blood goes from one side to the other.
Okay.
And we're trying to put together a theory that he was on an airplane. So, as you know, you can get clots in your legs just on a 6-hour flight. Mm-hmm. Could a clot from the leg gone? Travel. Usually it goes the wrong way. It usually goes to the lung. But sometimes it happens if you have a little hole in your heart called a patent foramen ovale. It could cross over and go into the brain.
Wow.
Didn't turn out to be that the case. He got better thank goodness, over the next 24 to 48 hours. But he absolutely had a stroke. And we're still looking at some of the testing. He just came in, as I said, over the last 2 or 3 days to see what the cause of the stroke was in order for him not to have another stroke.
It was great that he paid attention to his symptoms and didn't brush them off and went straight to the hospital, because every second counts with stroke care, right?
Absolutely. And I think that as we were talking before, every second means something, every minute means something. So if you cut off oxygen, really cutting off blood supply means cutting off oxygen to the brain. And for every minute that you don't have oxygen going to the brain, you lose 2 million brain cells.
Wow. It's a tremendous amount of brain cells.
And interestingly enough, with all the interventions that come in, we have some very nice, very good emergent interventions. Mm-hmm. But the windows of times are between 3 and 4.5 hours, up to 4.5 hours, for us to give what's called thrombolytic, or a sort of a drug, a clot buster.
Okay.
We can give a medicine through an intravenous that will dissolve the clot. And it's really back to plumbing. It's truly like Drano. It will open it up, and it helps restore that blood supply. Mm-hmm. In the old days, we had, talk about how we looked at things. We had a 3-hour window. So when do you think people would get their clot buster? At 2 hours and 59 minutes.
Oh, gosh.
Because everybody was looking to see, is their blood work okay? Yeah. To talk to the family, let's make sure they're okay with it, because there are some risks with it. About 6% of people have some bleeding with it. Mm-hmm. So the answer was we waited and we waited. Then the American Heart Association and National Stroke Guidelines came out and said, no, guys, don't wait 3 hours. Yeah. Do it earlier. So they cut the window back. When someone gets to the hospital, we want it done within an hour.
Yeah.
Now they're saying within 45 minutes. Wow, and even that's after getting a CAT scan, that's after getting some blood work, that's after evaluating the patient. Yeah. Because every minute you're losing those 2 million those brain cells. Yeah. And if you're losing those brain cells, they don't come back. A lot of the body does regenerate. Brain cells don't. They recircuit, but they don't grow back.
Okay, so extremely critical to address immediately. How often would you say healthy adults, realistically, should be thinking about stroke prevention?
I think everyone, you put them in a category. Cardiovascular, stroke prevention, all the same.
Yeah.
So it's blood pressure management, stop smoking, no lifestyle issues, exercise, things like that. So I think that's all in the same basket. Mm-hmm. So do I think everybody at whatever age has to worry about cardiovascular, cerebrovascular, brain, heart health? Yes. Mm-hmm. So I don't think there's a too early an age for that. I mean, we see people, and this gentleman who I mentioned who came back from that flight had a very, very high cholesterol level. Okay. So could that have been something that maybe if he went to his doctor at age 20 They would say, well, your cholesterol is very high. We need to go on a weight reduction program. If that doesn't work after a couple of months, we're going to start you on a statin or a medicine to get that cholesterol down, especially the bad cholesterol, which is very sticky, and to prevent a heart attack and, in this case, a stroke.
Yeah.
So we're looking to do things as early as we possibly can.
So in your experience, what's the most common reason that people delay going to the ER when the symptoms start?
So here's a question for you. If I had some numbness or weakness in my hand, and it was about 11 o'clock at night, and I had a choice between waking up my whole family or going to sleep and hoping that it gets better. A lot of us would go to sleep and hope that in the morning it's better. That's what too many people do.
Okay.
It sort of follows the Thanksgiving heart story. Everybody has a big meal on Thanksgiving, and then someone has some stomach or chest discomfort. Okay. What are you going to do?
Oh, they think it's because they're just too full. They overeat.
Exactly.
Yeah, they're going to ignore it.
Right. And that's the problem. Yeah. So there was a tremendous amount of education saying if you have any chest discomfort, you go to the front of the line in the emergency room. You don't wait. Wow. And basically you'll be seen. Yeah. Right now, someone who has a presumed stroke or symptoms that look like a stroke, they go to the front of the line. Yeah. They don't wait. They are seen immediately by an emergency room doctor. They get a CAT scan in our hospital. They actually get the CAT scan as soon as they come in. Wow. They maybe 30 seconds to a minute see the emergency room doctor. And I've been in the emergency room when patients have come in with a stroke, and I barely get to examine them. I see them, I'm running down the hallway with them, getting the CAT scan, which is more important than my evaluation, because I could look at them a few minutes later. Yeah. That CAT scan, once that gets cooking, we want to see what it shows, even if it's normal or not, and you can have a normal CAT scan initially. Very commonly you do. Huh. It's usually the MRI, and it usually lags behind by 24 to 48 hours, seeing it on a CAT scan. Okay. What we look for on the CAT scan is there's no bleeding. Gotcha. So then we can give all these thrombolytic agents, the clot busters, or at that same time we're looking to see the blood vessels. So we give them some contrast, and it takes a look at the blood vessels from the heart all the way up to the neck into the brain. Yeah. If we see a large vessel that's closed, then we call in our neurointerventional team. They do what's called a thrombectomy. So they go in just like with heart issues. They go in with these little wires through an artery in the groin usually, and they get to that spot and pull out the clot. Wow. And
is it almost like a little vacuum, or
yes, exactly. Okay. And they've changed it. That's perfect. In the old days, they used to just poke at it. Okay. And it didn't work. Because the stuff that they broke off caused more strokes further down.
I would think.
So for the first number of years that this procedure was out, it was actually deleterious and people were going against it. Wow. About 8 to 10 years ago, they came up with this idea that they could stick needles into it and suck it out at the same time. So the technology got better. So those little pieces that used to cause more strokes are all sucked out. So therefore, the benefit far exceeds the risk. Absolutely. And patients do much better. Okay. So that's gone on for the last 8 to 10 years. Wow. And that's the standard of care right now. And in that case, you can have up to 24 hours to do it. This is not the 3-4 hour window.
Okay, so you have a little more time.
You have much more time because if that area is clotted, you think about it, nothing is zero. Yeah. It is a little blood getting around it. It's going from what's called collaterals back to that area.
But it's causing a backup.
It's causing a problem, but you have a little bit more time. Yeah. Then if you could still pull it out and get a good response. We've had patients every week, and we had a patient yesterday who had a thrombectomy. Okay. And we do this very commonly. We have a team of neurointerventionalists. These are doctors who come in who specialize just in this and basically come in and try to pull it out. And there's a whole technique in how they do it. And they see how good the flow is after they do it. And we're very hopeful, and we see patients doing exceptionally well. We've had patients who had severe deficits. And deficits mean you can't talk, they can't move their right side. We call that the dominant side. Yeah. And it's usually the left side of the brain that handles speech and the right side. Okay. And in most people, that's their dominant side. People who couldn't talk, barely were awake, couldn't move their arm or leg. And again, not to say for everyone, but miraculously, getting that clot out fully and getting the blood supply restored, these people wake up in front of you. And they talk to you, and it's an amazing, amazing process.
That really is. Wow. What is the buildup exactly? Is it plaque? Is it the cholesterol?
Yes.
It is, okay.
It's cholesterol, it's platelets, it's a plaque.
It's a plaque, okay. Yeah. That's so critical. Have you seen cases where acting just a little earlier would have really changed the outcome?
The answer is yes, but now that we have that 24-hour window, we're better.
Okay.
When we had that 4.5-hour window, if you came in 5 hours afterwards and I couldn't use those clot busters, we all felt very badly.
Yeah,
now that we have this, we have a longer period of time. But yes, earlier is always better.
Okay.
And I think the biggest problem we have is the wake-up event. When somebody went to sleep with maybe mild symptoms or even no symptoms, and then they wake up, we don't know when it started.
Okay.
So we use something called the last known well time. Last known well time is when you go to sleep. So the clock started then, not
when you got
not when
up.
it might have happened.
Yeah.
And you should see us going around asking them, did you go to the bathroom at night? Did you get up? How were you? Maybe we could change that time.
Yeah.
But it's hard.
Yeah.
That window of time is relatively strict.
Okay. Do men and women tend to dismiss symptoms differently, you think?
I think they present differently. Same way with cardiac disease. Women oftentimes won't have the substernal chest pain. This is it's called the vein sign where people go like that. And with stroke, a lot of times women will have balance problems, headaches, some more nonspecific symptoms, numbness. Obviously, they can have the speech problems, the weakness, exactly the same syndrome as men.
Okay.
But it's something's a little different, and they've actually changed some of the words. The word is always fast.
Yes.
Face, arm, speech, time.
Okay.
Now we use the word be fast. And be fast. So B is balance, and E is eyes.
Eyes.
And that's sort of trying to bring in some of these more atypical syndromes, which we see with women, where their balance is off, they feel a little dizzy, they have a little blurred vision in one eye.
Okay.
Something that maybe they wouldn't recognize, but we're using those extra letters for us to recognize that and to tell people to get medical attention.
And when you mention headaches, is it a very intense headache? Is it just headaches that won't go away, or they're very frequent?
A lot of people have headaches. And a lot of people don't have headaches causing stroke.
Yeah.
And for people with migraines, especially if they have the aura, the visual zigzag lines, it actually is a risk. It is a risk factor for stroke.
Huh.
So it does increase